Good evening, Sabina ma'am. Namrata ma'am, shall we start exact 7?
Yeah, have all the other consultants joined?
No ma'am. Sabina ma'am joined.
Okay. Dr.
Yeah,
Ritu and Dr. Nishant and Abhinash are yet to join.
yet to join. Yes ma'am.
Uh, we'll see.
Okay ma'am.
First, anyways, is my class. I think we can start so that the session doesn't get postponed.
Okay ma'am. Good evening, Ritu ma'am.
Good evening.
Shall we start?
Yes ma'am.
Yeah.
Start.
So, good evening to one and all. I'm Dr. Namrata. I'm a medical oncologist currently practicing at Apollo Hospitals, Hyderabad, in the new branch that is the financial district. Today, let's go deep dive into endometrial cancers. So, the first session is mine, and it is on the latest molecular profiling in endometrial cancer. I also thank IAIO for giving me the opportunity to be the program director for this endometrial cancer course. And also, I welcome my other panelists, Dr. Abhinash sir, Dr. Savinay, and Dr. Ritu, and Dr. Abhinash, Dr. Nishant Sinha. Thank you. So let's start. The slides aren't going forward. I think I have shared the slides, right?
Yes
Able
ma'am.
to see my screen or?
No ma'am, not yet.
Sure.
Visible, ma'am.
Just a moment. So I wanted to start from the basics. So when we come to the epidemiology of endometrial cancer, it is one of the most common gynecological malignancy, mostly seen in the developed countries, whereas in countries like ours, cervical cancer initially, maybe 10 years ago, was the most common one. And the median age is around 65 to 70 years. And there are also other major risk factors like obesity, diabetes, unopposed estrogen, Lynch syndrome, and increasing age. And approximately 80% are initially diagnosed at early stage when the patient initially presents with postmenopausal bleeding. But if they ignore it later, they might land up in stage 3 or 4. So what symptoms do the patient initially present to our OP with? Postmenopausal bleeding, that is abnormal uterine bleeding, pelvic pain, backache, when the disease starts spreading more, that when it passes to the lymph nodes. And how do we work up a CA endometrium case? So the basic workup starts with transvaginal ultrasound, and mostly all our patients initially come from the gynec departments. And other after ultrasound, we get an endometrial biopsy, otherwise hysteroscopy when indicated, and MRI pelvis is done for the local staging. And routinely, we do PET-CT at our institute to know the disease status and stage. So what are the most common histopathological types? Endometrial carcinoma is the most common. Then serous carcinoma, clear cell, carcinosarcoma, undifferentiated carcinoma, and these are very aggressive types. So what is the molecular classifications according to TCGA? TCGA is the Cancer Genomic Atlas. So basically, there are 4 molecular subgroups. That is the pol ultra mutated, that is the polymerase E mutated, which carries excellent prognosis. The median PFS is around 92 to 100% for patients with pol ultra mutated, followed by the MMR deficients, that is dMMR or MSI high, followed by PTP53 abnormal or mutant, and the NSMP. NSMP means no specific molecular profile. And why is this molecular classification important? Because this prognosticates the further course journey of the patient, and it determines what adjuvant treatment to follow with. And also it predicts a response to not only immunotherapy, but other treatment too. So this slide is according to the latest 2025 ESCO-ESTRO guidelines. So when a patient presents, when we diagnose them with endometrial carcinoma, first what we do is we send for a endometrium cancer panel. In that, what they cover is pole mutation analysis. And if pole is positive, then they're diagnosed with pole pathogenic, that is pole mutant. And if there's no pole mutation, then what do we do? If we do in a stepwise manner is we check for the MSI status. And if there is any loss of MSX6 or one of those 4 variants, PMS2, MLH1, MSH2, 6, if this is lost, then we diagnose them with dMMR, that is MSI high. And next, what we do is TP53. If the patient is positive for TP53, that means they're TP53 mutant. If they're negative, that means they're TP53 wild type. And the last thing is, if the patient doesn't fall into none of these categories, then they're diagnosed as NSMP. That means no specific molecular profile. So recently, what we have seen is even in NSMP, we further do ER. So if the patient ER is more than or equal to 10%, that means they're graded as again low grade, grade 1, 2, and high grade. For low grade, it is called as NSMP low grade and ER positive. And if the patient's ER receptor is negative, that is less than 10%, and if they are diagnosed with grade 3, then it is called NSMP high grade or estrogen receptor negative or both. But a patient can have multiple mutations too, like they can have pole as well as MMRD. Then we still take pole as the significant one. They can also have pole and TP53. We still classify them as pole mutant. They can have MMRD and TP53. Then we take as MMRD is the significant one. They can have all these 3, that is pole, MMRD, and TP53. But still, if pole is positive, we always take them as pole mutant. So pole ultra mutated, these constitute around 7.3% of all endometrial carcinomas. They have the highest mutational burden. that is around 232 into 10 to the power 6 mutations per megabase, and is therefore termed as ultra-mutated. These genes encode the catalytic subunit of DNA polymerase epsilon, which is a key enzyme involved in DNA replication and repair. So the mutations in this domain of pole, they impair the DNA error correction, resulting in exceptionally high frequency of C to A transversion, and they produce this characteristic ultra-mutated phenotype of this group. They have an excellent outcome, and the PFS, as we have discussed before, is 92 to 100%. And mostly pole patients, they're younger patients, they have a low BMI, and they present at lower FIGO stages. Initially, there was Bokman classification, which was like type 1 and type 2. Type 1 belonged to the estrogen positive, the patients with obesity, hormonal imbalance, all these patients. This was the milder variety, whereas type 2 was the aggressive variant. Now from there, 10 years later, we have come up with this molecular classification. So 80% of these pathogenic mutations are concentrated in 5 hotspot residues within the exonucleus domain. And these are the variants. These are not important for us, but just if we go in detail. And approximately 40% of the tumors harbor rare mutations at other domain sites too, and whereas fewer than 4% exhibit mutations outside this domain. Pole mutations also occur in undifferentiated and dedifferentiated carcinomas, carcinosarcomas, and clear cell carcinomas. And this mutation status prognostically supersedes P53 MMR status too. And even tumors harboring concurrent P53 abnormalities or MMR deficiency, they retain the favorable outcomes when pole mutations are present. That means when we compare them with their counterpart, DMMR or TP53, these patients still tend to do better because they have pole. And histologically, if we see from the histological point of view, they are densely lymphocytic infiltrative, and they're likely driven by the high neoantigen load, which are associated with their extreme mutational burden, and they may also represent a potential target for immunotherapy. When we come to the MSI, this is the hypermutated subtype due to its next, when compared to pole, this is the next second one with the mutational, elevated mutational load. So it contains around 18 into 10 to the power minus 6 mutations per megabase. And whereas pole constitutes 7%, these constitute around 28% of all endometrial cancers. And they arise from either somatic mutations or the epigenetic silencing of the MMR genes. These 4 genes, MLH1, MSH2, 6, and PMS2. They are critical for, these genes are critical for the repairs done during the DNA replication. So what do we do when a patient presents with a DMMR status and with a positive high family history with other malignancies? Then we have to again check for BRAF mutation and also for hypermethylation of MLH1 to rule out whether they come under the sporadic type or they come under Lynch syndrome. And loss of the MMR function results in MSI instability and a hypermutated tumor phenotype. So MSI endometrial tumors frequently harbor mutations in PTEN, PIK3, ARID, and other genes, TP53. So how do we do the test? Through IHC, and this is a surrogate marker for MMR status. And the IHC assesses the nuclear expression of these proteins with complete loss of staining in the tumor cells, which is contrasted with the retained expression in surrounding stromal or inflammatory cells as an internal positive control, indicating the deficiency. Similar to the pole ultra mutated carcinomas, DMMR ones are predominantly endometrioid, that is almost 85%, and out of those, with nearly 50% exhibiting high grade morphology. So, and majority with DMMR are with serous morphology or immunophenotypic overlap, they're classified as endometrioid. So, like pole ultra mutated tumors, DMMR tumors also display prominent tumor infiltrating lymphocytes, reflecting their hypermutated and potentially immunogenic phenotype. And clinically, they demonstrate intermediate prognosis, but better than mutant TP53, but less favorable than pole positive cases. And they also have a variable prognostic behavior across other histotypes. And in early stage, low-grade endometrial carcinomas, DMMR, they paradoxically increase the risk of recurrence, whereas high-grade endometrial tumors with DMMR typically have intermediate outcomes. And DMMR status in the non-endometrioid carcinomas, they confer a better prognosis when compared with their TP53 abnormal counterparts. The third one is TP53 mutant. Tumors with a low overall mutational burden, they're further divided into two categories, that is copy number high and copy number low, that is CNH and CNL. And recurrent genetic alterations are also present in these tumors like PIK3, CCNE1, ERBB2, and MYC. And the copy number high, that is TP53 mutant, largely corresponds to type 2 endometrial carcinomas, and predominantly they comprise tumors with serous morphology, which are considered aggressive. And these tumors typically arise in older patients and they present at advanced stages, and they're also associated with poor prognosis. IHC serves as a surrogate marker for P53 status, showing three primary patterns, that is overexpression, complete loss, and cytoplasmic expression. So overexpression, 85% of tumors are characterized by strong nuclear positivity in almost 70 to 80% of tumor cells. Complete loss is seen in around 11.5%, while the cytoplasmic expression is minimal, occurring in only 2% of the tumors. So correlation of TP53 with pole and DMMR is very essential, as both molecular alterations supersede P53 expression in prognostic significance and influence the management decisions, which shows the histomorphological pattern of the CNH subtype, serous type of the EC, that is endometrial cancer. The P53 immunostain, that is the surrogate for TP53 mutations, shows both null and diffuse pattern of staining in mutated tumors. And these tumors are generally very aggressive. Even in stage 1, if they present, they're still considered very aggressive with chances of high recurrence. And they demonstrate high rates of recurrence and poor overall outcomes compared with the other subtypes. And the last one is NSMP. It is the prototypical type 1 EC of the Bokman classification, which we initially discussed. So low to intermediate grade endometrial carcinomas, and they arise in patients with unopposed estrogen exposure. So among the TCGA molecular subtypes, this is also called as CNL low NSMP. That is, CNL low is copy number low. It is the most prevalent and it represents 40% of all endometrial cancer cases. And it neither exhibits a high mutational burden nor significant copy number alterations, and they're generally MSS, that is microsatellite stable, and they lack a pole in TP53. So recent refinement is we are doing a subtype in this, that is an IHC again called ER. So patients with ER positive are still considered good risk, and patients with ER negative with high grade are considered bit aggressive in this NSMP subtype. And we are also now additional markers, biomarkers, which are in the recent developmental stages include L1-CAM, that is L1 cell addition molecule, that progesterone receptor and beta-catenin mutations. They're under investigations. And the last thing is, in this NSMP type, Borojny analyzed the molecular profile of NSMP, and he identified three distinct clusters based on the genetic alterations. That is cluster 1, 2, 3. Cluster 1, we see recurrent PIK3 and PTEN alterations. Cluster 2, we see co-occurrence of PTEN and PIK3CA. And cluster 3 has KRAS. Out of all these, cluster 3 is the most aggressive variant. So as we are developing the newer molecules and doing more research, NSMP again, we are doing an ER thing. ER positive, it is considered a good risk. ER negative with high grade is a very aggressive type. And also in NSMP cluster 1, 2, 3, out of which cluster 3 is very aggressive in among 1 and 2. So initially, when we were studying, there was only type 1 and type 2 in endometrium. Slowly, this molecular classification has started, and treatment according to the molecular classification has started. In that, now again, we are finding more subtypes. Even previously, when we see breast cancer, we used to see only if it is small lump, you go for surgery, a bigger one, give chemos. Then slowly, we started subtyping it, luminal A, luminal B, TNBC, what to give before, take up for surgery or give immunotherapy. That is how it is moving forward. Thank you for the opportunity.
Thank you very much, ma'am, for that insightful presentation. We move to our next session. It's my pleasure to invite Dr. Ritu Singhal, Consultant Medical Oncologist, Mittal Hospital, Raipur, to deliver this important talk. Over to you, ma'am.
Thank you very much. Minute. Are my slides visible?
Yes, ma'am. Visible.
Okay. Good evening, everyone. My name is Dr. Ritu Singhal, and I will be discussing about the precision oncology in endometrial carcinoma beyond the MMR status. So, Madam has explained very nicely about the alterations in the endometrial cancer, the molecular alterations, and we have went through the pole, MSI, the P53, and the NSMP variations. I will just quickly go through this again. So, as we know, there are four molecular alterations mainly in the endometrial cancers. That is like poly sequencing, MMR, and the P53. So it's like a sequence. We first begin with the pole sequencing, and if it is a pole mutation, it becomes like a pole hotspot mutation, and it will be labeled as pole mutant. Even if we don't do MMR or P53, it is still overrides everything, and it will be labeled as a pole mutant. Now, if the pole becomes negative or it is non-mutated, then we go ahead with the MMR, which is a counterpart of the MSI and the immunohistochemistry part. So if the MMR is lost or if the MMR is deficient, it will be labeled as MMR and it will be overriding the P53. So we know that P53 in all the cancers is a poor prognosis and a poor subset. So even if the P53 is there and the DMMR co-mutation is there, we'll still consider the MMR deficient as the superseding one. So that endometrial cancer will be labeled as DMMR. Similarly, if both are negative, we'll go ahead with the P53. If it becomes a P53 mutant and pole and MSI is negative, then it is very important to look at the P53 because it will be beneficial in the adjuvant setting of the endometrial cancer. The treatment will be there. Last is this NSMP, and it is also accompanied by the ER positivity and ER negativity. So we'll go ahead and discuss the each of these and the role in the treatment of the endometrial cancer. So these molecular classification is just not the classification. It is also a prognostic biomarker. Like if the patient is having a pole mutant and rest of this is negative, that will be a very good prognosis for the patient. Similarly, if P53 is there, obviously it is a bad one. In every cancer, P53 is a bad prognosis. So when it comes to the poly mutation, as Madam has also already discussed the role of poly and the DNA polymerase, it is so if the mutation is there, the proofreading will not be there and it will be very unstable. The tumor will be very unstable, and this poly ultra mutation will lead to generation of very high neoantigens. Now these neoantigens are like a magnet. Like these magnets will attract all the PDL1 and not the PDL1, but the T cells, and it will become very, very immunogenic. So poly is around 6 to 13% present in the endometrial cancer. So this is like the Estro-ESGO classification of 2025, and like up to 2C also. When the poly is there, it is still labeled as a low risk. So low risk, we don't need any adjuvant therapy. Similarly, the MMR and the P53 is also there. It is classified according, the stages are still classified according to the endometrial cancer, according to this molecular classification. And hence we treat according to this molecular classification. So like earlier it was based on the just stage. The stage, like if the patient is having stage 2, stage 4, we'll just treat according to the stage. But now when it comes to the uh, molecular this molecular classification, it is still, even if the stage is 2C, the stage the poly is there, still we can keep the patient on observation rather than P53. Like if everything is negative and in still it is 1A and P53 is mutant, we'll still treat as high risk and give off all the chemotherapy, the brachytherapy, and the EBRT. So we'll come one by one. So although my topic is beyond MMR, but it is very important to talk about the MMR. Like there is one deficient MMR, and others is considered as non-DMMRD. So we'll not label it as a proficient MMR. We'll label it as a non-DMMRD. So when it comes to the deficient MMR, that is present in 16 to 20% around in the endometrial cancer. And these POLE and MSI both are highly immunogenic. So these attract the immune checkpoint inhibitors. Like POLE ultra mutation is there, it creates a very high tails, high neoantigens. Similarly, MSI also creates a very immunogenic environment. So these attracts the all the T cells and make it very immunogenic, which is very highly responsive to the immune checkpoint inhibitors. So why do we have introduced immunotherapy in the endometrial cancer? Earlier we used to treat with just paclitaxel carboplatin, but now we have introduced immunotherapy also in endometrial cancer. But it's not beneficial in everywhere. Like if the patient is having poly ultra mutation is there, and that is a very high neoantigen load is there, high tails is there, and this MMR, MSI, DMMRD is also the same, but it doesn't depend on the PDL1 expression. Though the PDL1 expression is high in all this, but the treatment doesn't depend on the PDL1 expression. So what is the evidence? What is the rationale of adding these immune checkpoint inhibitors? So this we have seen that dostarlimab and durvalumab, pembrolizumab, these are the trials like Keynote 158 Garnet. These are in the subsequent lines. They have used single agent immunotherapy in the DMMR and a PMMR endometrial cancer. And the IO monotherapy in the DMMR is showing a very high overall response rate of around more than 50%, rather than the in the PMMR, which is less than 15%. So with this, why don't we combine with the chemotherapy and put it in the first line? So this was in the first line. These in the deficient MMR, we have like NRG-GY, which is Pembro plus paclitaxel carboplatin. Ruby is there, which is using dostarlimab. Attend is there, which is using atezolizumab. Ruby Part 2, which is incorporating Duoin, and Ruby Part 2 is also incorporating the PARP, which we'll discuss later on also. So we have seen the DMMRD is behaving very nicely when adding the immune checkpoint inhibitors in the first line along with the chemotherapy. Now, similarly, in the proficient MMR is like non-DMMRD. They don't have much of the tails, they don't have much of the immunogenicity. So how do we see this? In the NRG-GY, though it is showing that very good hazard ratio is there in the overall survival, adding the pembrolizumab, immune checkpoint inhibitor. But when we see the updated results, it is showing that gradually over the time of 1.5 years, the hazard ratio keeps on rising. And in the end, the hazard ratio is not showing the good benefit of adding pembrolizumab in the proficient MMR. Similarly, you can see the ATTEND trial, the atezolizumab in the proficient MMR. Look at the hazard ratio. Hazard ratio is just 0.92. It is so detrimental. While in the DMMRD, it is 0.36. So these show that the high tails and high TMB and the this high new antigen load, if we add the immune checkpoint inhibitor along with the chemotherapy in this subset, it will be beneficial in the first line also along with the chemotherapy. Now, what is we have also seen like this is the PDL1 expression. Now you can see that the darker areas here. Now the PDL1 expression is very high in the poly and MSI, while this is the MSS1 or the PM or the non-DMMRD. It is so low. So can we make the PDL1 expression as a predictive or a prognostic biomarker? So they have, though that is not powered, all the trials were not powered because of PDL1, but they have seen in the subset analysis that doesn't make a difference. Even if the PDL1 high is there, so if the PDL1 score is high or PDL1 score is low, we don't rely on the PDL1 scores to add the immune checkpoint inhibitors in the endometrial carcinomas. Now, so there is a TKI with the immune checkpoint inhibitor. We have covered the poly. Now, poly is just a good prognosis, and a good prognosis poly, we just have to make the observation in the low risk. When it comes to the DMMR is a very high neoantigenic subset. So we add immune checkpoint inhibitor and a chemotherapy. Now, what about the non-DMMRD? Or I can even say like PMMR. Can we add immune checkpoint inhibitors or TKI? TKI is a lenvatinib. Now, this is like the subsequent subsequent line, not the first line. So in the keynote 775, they've seen that the lenvatinib plus pembrolizumab, that is TKI with the pembrolizumab, was used in the treatment of advanced endometrial cancers. But they were exposed to the prior platinum chemotherapy. They have used platinum, they have used Lenva and Pembro as compared with the subsequent lines of the endometrial carcinoma post paclicarbo. Like post-paclicarbo, we can give doxorubicin. So this is like second line they have compared with the chemotherapy. So they was showing a good overall survival in the all-comer, like PMMR and the DMMR. But in the PMMR also, they were showing a very good hazard ratio of the OS of 0.64. But that was not in the case of DMMR. Like they have seen in the first line also. In the leap is for the first line Lenva Pembro. But they have seen that it is not beneficial in adding, is not beneficial of adding Pembro plus Lenva in the first line in the PMMR setting. So when it comes to the summary of this like MMR and this what we have discussed yet, like Ruby trial, Attend trial, NRG, Duo, these are the 4 trials mainly which we have used and which we are using in endometrial cancer, like immune checkpoint inhibitor along with the chemotherapy. These are the 4 trials. Like Ruby is the dostarlimab with the chemotherapy, Attend is atezoli with the chemotherapy, NRG GY01 it is the pembro with chemotherapy, and Duo is the durvalumab with the PARP inhibitor along with the chemotherapy. Now, all the trials were powered for the PMMR, except the DOE, which we'll discuss later on. Now, we can see that the PFS in the DMMR and the PMMR in the all the trials and the OS in the DMMR and the PMMR, we can see that the deficient MMR, all the trials were having a good PFS and a good OS. But when it comes to the proficient MMR, like the hazard ratio keeps on falling. Only the NRG is there, it is 0.54. But as we have already discussed, the OS has also decreased. PFS they have not seen, or rather, we have not looked into the PFS, but the updated result of the OS, it is showing as it has decreased from the hazard ratio from 0.54 to now 0.79. So it is not a good therapy, like just if the patient is having non-DMMRD, it is rather not to add immune checkpoint inhibitor in the along with the chemotherapy. Look at the hazards ratio 1, 0.79, 0.91. So rather we can just see the MMR. So it's not just a predictive biomarker, prognostic biomarker, but also a predictive biomarker. So we have to do the MMR, and if the MMR is there, and if the patient is a candidate for the immune checkpoint inhibitors, then it is beneficial in adding the immune checkpoint inhibitors. This is a short summary which I've prepared. Like in the DMMR, this PARP I'll discuss later on in the subsequent slides. So there's a DMMR and the non-DMMR. So adding immune checkpoint inhibitor along with the chemotherapy, or the PARP inhibitor along with the immune checkpoint inhibitor along with the chemotherapy. In the DMMR, just remember that the immune checkpoint inhibitor along with the chemotherapy is always beneficial rather than in the PMMR. PMMR, only this short benefit is there of the PFS adding, but in short, DMMR, immune checkpoint plus chemotherapy. In PMMR, add PARP along with the immune checkpoint inhibitor and the chemotherapy. So in short, DMMR, only IO with chemotherapy. PMMR, PARP plus IO plus chemotherapy. So what about a TP53? Now, TP53 is a bad like mutation. So everywhere TP53 is a notorious mutation and it causes a bad prognosis. What is the rationale for combining the PARP along with the anti-PD-1? We have seen that we have added PARP inhibitor along with the IO and the chemotherapy. Why in endometrial cancer? Endometrial cancer PARP is also there. So like when we inhibit the PARP, it increases the expression of the neoantigens. The neoantigens we have already discussed. When the neoantigens is increased, there is increase in the immune checkpoint inhibitor activity. So these PARP inhibition increases the neoantigen activity of the tumor cell and increases the immune checkpoint inhibition action. So when it was used in the in the proficient MMR, like proficient MMR was not working properly in the immune checkpoint inhibitor along with the chemotherapy. But when we add the PARP inhibitor, it increases the immunogenicity of the tumor cells. So now the immune checkpoint inhibitor works better. So that's why PARP plus IO plus chemotherapy in the proficient MMR works better than the DMMR. So this was the Duo-E study. Duo-E is what? Like Duo. So 2 things were used. One with the 3 arms were there. Paclicarbo, Paclicarbo with Durva, and Paclicarbo with Durva followed by Olaparib. So only Durva maintenance was, only no maintenance was there, only Durva maintenance versus PARP plus immune checkpoint inhibitor maintenance. So when this is an interesting slide. Now, so now when we see that the subgroup analysis of the MMR status. So this you can see the DMMR. This is the PMMR. So this is an interesting slide. Like DMMR, you can see the hazards ratio, like adding durvalumab and adding olaparib. When we add the olaparib to this DMMR subgroup, you can see that there's not much of the hazards ratio change, like 0.42 to 0.41. So is it like only the thing which is acting here in the DMMR is the only immune checkpoint inhibitor? But when we see in the PMMR, see that when we add only the immune checkpoint inhibitor is like 0.77. But when we add the olaparib, like PARP inhibitor is used, the hazards ratio comes down to 0.57. So here, the olaparib is working better. Like the PARP inhibitor is working better, and the immune checkpoint is enhancing the hazards ratio of this subgroup. Similarly, when it comes to the subgroup analysis and the biomarker in this DuoE, so there were also not with the PMA, there were coexisting mutations also, like purely TP53 along with the MMR status. So when it came to be like T53 were performing better. So like T53 is a bad mutation, but when we have to give the drug, if the P53 is there, it works better and the outcome is better. Similarly, in the Ruby part 2 also, Ruby is again in the with the PARP inhibitor. So we have discussed two PARP inhibitors. One is the DuoE and another is Ruby Part 2. Now Ruby Part 2 is again combining immune checkpoint inhibitor along with the IO, immune checkpoint inhibitor along with the PARP inhibitor. So when we see the addition of this, like overall population, the hazard ratio is 0.6, this PFS benefit. In the PMMR also, adding this is causing hazard ratio of 0.63. Again, the P53 is performing better, the hazard ratio of 0.29. So it is like when we go back to this slide, yeah. So like DMMR, we have discussed like IO plus chemotherapy performing better. PARP, we have seen there is no benefit. The hazard ratio was 0.42 and 0.41. Similarly, in the PMMR, the PARP plus IO plus chemotherapy is performing better. Maximum with the T53 and the NSMP group. So this is like a short summary till now, like poly, MMR. Now there is another subset like NSMP is there. So we have like P53 is not there, MMR is not there, poly is not there. What about NSMP? NSMP is non-specific molecular profiling, but this non-specific molecular profiling still holds some benefit. Patients can be ER positive or ERPR positive or ERPR negative. So if the patient is ERPR positive, we know that in the breast cancer we give hormone positive and HER2 negative patients a chance of CDK4/6 inhibitors. So why not in endometrium? This paleo trial has taken into account when the hormone positive is there and we give palbociclib plus letrozole in these patients, the median PFS is increasing from 8.3, from 3 to 8.3 with a hazards ratio of 0.56. So there's like a prognostic and also a predictive biomarker, this NSMP. Now, another profiling is the HER2 when we don't have anything. Yeah, but the one thing in the HER2 thing, when we have to check for the HER2. Now, if the patient is having poly mutation, there is not much of role of checking for the HER2 mutation, as there is HER2 positivity is like zero. Only time when the aggressive biology is there, like P53 is there, it can coexist with the HER2 mutation. Almost 13.7% will be having HER2 mutation along with the T53. So whenever we get a T53 mutation, the MMR is proficient, poly is negative, NSMP is negative, but P53 is abnormal, which is most of the times P53 will come. So we have to check HER2 also in those patients. So even if we don't have a targeted, you can say targeted drug for any P53, but we can target HER2 in these patients. HER2 can be positive. 13.7% is coming positive in these patients. So adding trastuzumab in those patients in the T53 coexisting with the HER2 will make a beneficial thing for the patient. So when we conclude, this is a slide we have taken from ESMO, like pole E mutant and the deficient MMR. We have discussed these are very highly immunogenic areas. So we have to add chemotherapy with the IO. And when the proficient MMR is there, or like non-DMMRD is again what T53 is NSMP. Now we have seen the non-DMMRD or the proficient MMR is working very good with the PARP inhibitor. Now, if nothing is there, we can add hormone. Now, this is like Expo 1, something new is there, Expo 1 inhibitor that is selinexor. But it has still has to be available in India, and we still have no hands-on like usage on the selinexor. As far as I have not used, and uh, obviously we cannot use now. And others are ADCs. ADCs again, like FAM trastuzumab deruxtecan. TDXD is the last option. We have TDXD and others like we have NTEC. NTEC is there. NTEC we can give larotrectinib and entrectinib in those patients. These are like out of if we have exhausted everything and we don't have any other biomarkers, we can check for the P53. We can check for the PIK3CA, ARID1A. We can check for the NTREC variety, and we can give like the targeted ones like larotrectinib, entrectinib, and NTREC, and others is like end may we have tumor mutation burden. High TMB is again we can use in the end pembrolizumab. So this is like a short conclusion and the short drugs we can use along with the molecular profiling. So I've tried to incorporate as much as in a short time. Hope it will help for the decision making. Thank you. Thank you so much.
Thank you, ma'am. Thank you for your excellent presentation and valuable insights. We now arrive at one of the most anticipated segment of today's program, panel discussion, real-world challenges of cases and controversies. Moderating this session is Dr. Nishant Sinha, Senior Consultant, Medical Oncologist, Shri Mahanta Indresh Hospital, Dehradun. And joining him as panelists are Dr. Savinay Ardikya, Consultant Medical Hemato and Pediatric Oncologist, Blood and Cancer Institute, Surat, Dr. Avinash Patnaik, Assistant Professor, Department of Medical Oncology, IMS and Some Hospital, Bhubaneswar, Dr. Namrata Sai Reddy, Consultant Medical Oncologist, Apollo Hospital, Hyderabad, Dr. Yamini Kansal, Associate Professor, Department of Gynecological Oncology, SGRRIM and HS Dehradun. I now invite Dr. Nishant Sinha to kindly take over the panel discussion. Over to you, sir.
Hello and good evening to everyone. Just a second, I'll just share my screen. Okay. You have, yeah. I hope the slides are visible, my screen visible, and I'm properly audible.
Sir. Yes, sir. Visible.
Okay. So, just a second. Yeah. So, shall we start now?
Yes, sir. Sure.
Yeah. So, thank you for this opportunity. And at this outset, I would love to thank to the team for so beautiful session and so delightful to share the case, and we can discuss a little more about the endometrial carcinoma. So the case that I'm going to discuss is a very simple, actually, metastatic endometrial carcinoma, so that we can discuss all the possible options and offerings to these patients of endometrial carcinoma. So
Sir, sorry to interrupt, sir. So
Yeah.
Yamini ma'am will be joining shortly.
Okay.
Yeah.
So can we shall we wait a little bit or what?
Sir, we start. She will join shortly.
Yeah. Okay. Yeah. So just discussing, so personally being a medical oncologist, I always I do get confused with a lot of things there in the endometrial carcinoma. In last few years, it has become very exhaustive as well as interesting, and we have gone down to the molecules, and it's now no more a very straight away approach, rather a very molecular approach that we have for the endometrial carcinoma. So here, the case is a classical case that we see in our OPDs. That is, so that's a 62 years old woman with the typical complaint of postmenopausal bleeding, pelvic pain, and weight loss for about 6 months. She's a known case of hypertension, diabetes mellitus, and high BMI, and PS was fine for the patient. So the patient came to our clinic, specifically in the gynae clinic, and she was being worked up. And I would directly go to the important findings that we had. In the MRI which was done, it was suggestive of a uterine mass. Okay, along with that, CT and other workup was done, which was suggestive of lung nodule, paraortic nodes, or mental diseases, and a CA-125 was done, which was suggestive of 112. So I would like to ask our esteemed panelist that how often, or as we say that it's a metabolic disease and it's mostly seen in obese women and all. So can you just, with your experience, can you share me like what kind of patients you find with endometrial carcinoma, be it metastatic or non-metastatic, in our setups, are in specifically for Indian setups? Are they specifically obese one or the lean endometrial carcinoma? Do you find a difference between the profiles of the patients you find in their OPDs, and how are they in general different? Like you find them more aggressive in a obese one, or more with the lean endometrial carcinoma? Can anyone of
So,
you can just
sorry to interrupt, sir. Sir, your shared screen appears to be very small.
yeah,
So, do you be mind switching to full screen or increasing the zoom so the slides are easier to read?
okay. Is it okay now?
Okay, sir, fine.
Okay.
Mm.
Yeah. So I would like to involve the panelists that with your experience, can you just put an insight into the kind of profiles of patients that you find in your OPDs with in terms of their BMI and how metabolically complicated they are? Anyone?
Good evening, sir.
Yeah,
This
hello,
is
ma'am.
Dr. Savinay.
Hello, ma'am.
With respect to the profile, sir, I would like to say that fortunately, only 15 to 20% of the cases I do encounter in stage 4.
Yeah,
Most of them do come after their staging laparotomy is done, and
yeah,
most of them either are stage 2 or 3 to me, because stage 1
yes,
obviously most of the
yeah,
times do not come to me.
yeah, yeah.
And secondly, majority of the patients, sir, I would say that around 70 to 80% of the patients do have higher BMI. And
Mm-hmm.
retrospectively, I have noticed there's those who are having a very good prognosis as compared to the patients who are lean to me
Yes, yes,
when present. So this
yes,
is
yes.
just my observation. I don't know. Maybe
No, no,
then
actually, ma'am, that's why
this is
I actually specific. It's a very basic thing that I talked about. But actually, I have also found this that the patients with a leaner body mass and endometrial carcinoma, they perform poorer. So, and actually, it's the truth
yes,
that normally endometrial carcinoma comes in early stages, or they come in a metastatic stages only once they have been treated. They have a history of treatment or something, but neglected patients may come as in stage 4 to present with. And yes,
yes,
I have
sir,
also
yes,
seen
sir.
that these the leaner endometrial carcinoma is actually having somehow more the biology is not that good.
Yes,
Namrata,
sir.
ma'am, you have any insight to
Hello,
it
sir.
if
Uh,
according to you? Yeah.
yeah. Even I go ahead with Dr. Savina's same. Even I conclude with the same thing. But the thing is, when we have seen the data with the poll, they said that poll has patients with
Yeah.
younger and leaner BMI.
Yes. Yes. And on
So
a contrary, poll is a good one.
yeah. And even we have seen few bad poll people with poll mutations who have done very
Yes.
badly too.
Yes, yes,
Um,
yes, yes. So I think this data, which normally we talk about endometrium data, is what a lot of Western data that we have, where
hmm,
the habitus and the obesity is little different. What obesity we have. Okay, so I
true.
since currently earlier when I was in AIMS Delhi, it was a different scenario, but here in Uttarakhand we have comparatively the patients coming from the hilly areas and the Himalayan terrains. They're overall very fit. Overall, I have found them to be fit enough, and their habitus is in general not, I would not say lean, but not very obese as well. So
Hmm.
that is there. So Yamini ma'am has joined. Ma'am, thank you for joining. Ma'am, we were discussing the case that it's a BMI of 35 years old. Hello, ma'am. So BMI of
Hi,
35 years
Dr.
old.
Shant. Thank you to the organizers and Dr. Shant for the opportunity. Like, happy to be a part of this. Yes, please continue. Sorry to interrupt.
So, ma'am, actually, we were
Yeah.
discussing that we often see in our clinics now, ma'am, like the obesity and the endometrial carcinoma goes hand in hand. So, the habitus of patient that we find in our clinics. So, what is your experience, ma'am? Because you are looking into this disease for very long, ma'am. How you find the biology of a leaner endometrial carcinoma poorer as or a thicker endometrial carcinoma poorer in the performance, like the lean endometrial carcinoma versus a obese endometrial carcinoma?
Yeah, hi. So yes, so the obese endometrial cancer, it is, even though Uttarakhand is typically like a tier 2 or a tier 3 city, but the population of main Dehradun, I think we see more of the type 1 endometrial CA with obesity, which typically present with well differentiated, and oftentimes there's a lot of polyps also which come with the post menopausal bleeding. Many of them turn out to be polyps, even though the imaging is showing complex and thickened ETs. And compared to that, the lean patients which come with endometrial CA, more often they are the sarcomatous varieties, like the sarcoma, endometrial stromal sarcomas. I find them to be more common than the serous endometrial CA. Serous endometrial CA, relatively less, grade 3 and serous endometrial, even though in textbooks or other places we see that the lean and thin patients, they turn out to be serous endometrial or grade 3. Here we are finding either the typical type 1 variety or the sarcomatous tumors which come out in the leaner patients.
Normally the leaner populations actually comes with a poorer biology overall as compared to the thicker one.
Yes, poorer biology, including the entire spectrum.
Yeah, that's what Dr. Savine has also pointed out, ma'am. But Dr. Namrata actually put with a very correct point that, ma'am, ki the text write that pole mutation is more common with the linear varieties in general. That what text says.
Yeah,
so
correct,
that is
correct.
So that is something which is contradictory what went. But what I feel like the data is mostly driven by the Western world, ma'am, which is different from the our data in general, ma'am. The patient how they present with us. So ma'am, next, just going ahead with the case. So it's a case of, ma'am, uterine mass with, and to present with the patient had a lung nodule, paraaortic nodes, or mental diseases. So, and as discussed by other panelists also, to come with a upfront metastatic endometrial carcinoma is again quite not that common. We find it either a history or then progressing patient on it. So, ma'am, like Dr. Namrata, like how often you find a upfront presentation of a metastatic C endometrium without any previous history or something like upfront presenting with?
Maybe around 20 to 30% is what we see at presentation metastatic disease, but majority, sir, we see with the stage 1 or 2.
Yes. And
Yeah,
Dr.
I
Sabina,
think
if you have.
one more point I would like to say, that
Yeah.
because we are in the field of oncology, so probably Dr. Namrata is seeing 20% as metastatic in endometrial CA because being an oncologist. But I think if we see general gynecologists, for them it would be in stage 1, like almost 95% of patients like coming in early. But the ones who land up reaching like that might be a biased figure. That's all I want to say. Like the ones which reach a medical oncologist might be a biased figure compared to the real like distribution.
And many a times we find that these patients have a history of previous hysterectomy, which we do not actually have a proper data or a proper record of these patients, ma'am.
Definitely.
So what, according to you, are the most important factors, ma'am, that brings to a poor outcome of a stage 1, stage 2 not properly treated earlier? Or what are the basic surgical point of view, say, ma'am? What could be the major things that make the patient land into the metastatic disease early?
Last 2 months, like I saw 2 patients of endometrial CA who came back with metastasis, and both of them were like sort of incompletely evaluated during surgery. One was a grade 3, had no nodal dissection, operated by a gynecologist. And even though the patient was advised that you are supposed to go in for adjuvant therapy at a higher center, once the surgery is done, patient is very reluctant to get the chemotherapy part. So they just feel that the surgery is done, tumor is removed, and they are very much reluctant for the chemo part, and that's why they relapse within a year. The second patient also was exactly the same scenario, that cervical stroma infiltration stage 2, nodes were negative, but they defaulted for, again, P53 positive. But they defaulted for the adjuvant chemotherapy, landed up in a very bad metastasis within less than a year. So I think the grade 3 and P53, yeah, grade 3, P53, both of them.
And properly treated early stages, ma'am.
Yes.
Sir, sorry to interrupt you again, sir. Actually, we kindly request you to share your screen in a presentation mode.
Yeah, is it fine now?
Yeah.
Is it fine now?
Yes, sir.
Yeah. Okay, so it is to present with the patient comes out to be a metastatic endometrial mass. So the patient was done, a biopsy was done, which is just of high-grade endometrioid carcinoma, FIGO stage 4B, LVSI was present, omental deposits were fine, were found. So directly asking Yamini ma'am, tell me one thing, like if like how much what least metastatic disease you have that you can operate, like you find it to be a salvage operation or surgery can be offered to the obviously this patient is quite advanced, but if a patient comes to be only mental disease or only abdominal disease, so how often we can operate such patients and what are the outcomes as such? Or do you want any before the surgery, you want any systemic therapy to reduce the disease, debulk disease, and then go for a surgery on it?
I think in endometrial cancer, the guidelines are pretty clear that especially upfront, if the patient is presenting with even like metastasis limited to the dominant pelvis, that is when, if we feel that we can achieve a complete cytoreduction, we should definitely go ahead for surgery, even if it's parametrial involvement, because as gynae oncologists, we are doing advanced surgeries for ovarian cancers. So similarly, in endometrial cancer, there are clear-cut guidelines that if we can do a complete cytoreduction, we can go ahead at even in stage 3 disease or omental para-aortic nodes, they can be definitely tackled. Only thing is we should be very sure that it is not, there are no micrometastasis beyond. For example, like in this case, there are lung nodules. So the workup should be adequate to rule out a distant mets, because in that case, doing a surgery will just delay the chemotherapy, which becomes more important in a further metastatic disease.
Yes, yes, yes. And Dr. Namrata and our other team, ma'am, how do you find like your surgeons asking for any as ma'am has pointed out that only pelvis disease or something. So is there any good role or your experience regarding any induction kind of therapy or any chemotherapy, systemic therapy to start with, and the surgeon intervenes for a cytoreduction or something?
Maybe if the patient is really very old, not fit for surgery upfront, inoperable, I mean, medically she's not fit for surgery, maybe then we go ahead with
Any systemic therapy.
systemic therapy.
Okay.
And also sometimes we find cases where they have been incompletely staged without not doing any pelvic lymph node dissection, or the specimen being morcellated tissue if we get. Those cases, again, we need to do a resurgery, relook one.
Relook and the systemic therapies if required.
Yeah.
Okay. So, and after that, what are the next step that we go ahead? Like Dr. Namrata or any one of you can take up what next investigations you go ahead with? What is your take over the, if it's hardcore metabolic, it's a metastatic disease, then what next step or the investigations that you generally perform at your setups and your clinics?
Even for carcinosarcomas, there is data set for sending
Yes.
the molecular profiling. So for all
Yes.
patients, we do send the endometrium cancer panel.
Mhm.
So, but the thing is, should we do it on the initial biopsy piece, or
Yes.
should we do it on the final post-op histopathology?
Yes.
Because NCCN says you can either do it on the biopsy or the final histopat.
Yes.
But according to what we have seen in the ESMO and other guidelines, we need to send the initial tissue.
Initial. Yeah.
What I have read, they have said is we need to send the initial biopsy because we can prognosticate and it is time saving. Do you feel the same, or is there any other
Ma'am,
reason?
I do feel the same, and I think Yamini will also
Yes.
give us an insight that it's always the baseline tissue or index tissue that should be sent. Untouched tissue kind of should be sent for the any view on this, ma'am, Yamini ma'am?
Yeah, the guidelines do suggest, and a lot of pathologists do suggest that the initial biopsy should be sent for profiling. So there is one benefit that sometimes maybe like the extent of the surgery can be altered. For example, if the patient is a bit medically unfit and she turns out to be polymutated, in that case, probably we can omit the nodal dissection, and because the prognosis will be good.
Yes.
Similarly, in P53 mutated, even though lymph node dissection is indicated in a P53 mutated, but that can tell us that anyways she would be getting adjuvant therapy. So that is a gray area, that whether lymph node dissection can be omitted. We do go ahead and do both pelvic and para-aortic in those. And the second thing is, many a times we find, like I have encountered many such cases, that the initial biopsy, we did a thorough DNC, and that turned out to be endometrial CA. And in the final specimen, there was no residual tissue. So
Okay.
that's not uncommon because the whole of the tissue has
Okay.
been removed in the DNC
Yes.
specimen. So sometimes there's no tissue left in the
So
final
actually, it
specimen.
is wise to get it done at the baseline only, ma'am.
Yeah,
It's wise
those are
to.
the recommendations. Like
Yeah.
what our pathologists, I think they see both, and then they decide that whichever specimen they get the most amount of tissue, they are doing it on that.
And Dr. Namrata and my team there. So, what molecular profile normally you go ahead with? What is that panel that you're talking about? So, what that all includes in your setting?
Uh, Sorry, sir. You mean
Like,
the immunotherapy
no, no,
combination?
no. So, what that you said, na, we go for the molecular profile, the endometrial carcinoma molecular profile. So, what in your day-to-day practice, what least minimum tests you get at when you talk about the molecular profiling done for these patients?
Majority of our patients do accept, they go for the complete panel, sir. What we see most commonly is either insurance. Majority will be having insurances. In
Yeah.
case
So
the
we can
patient
actually
doesn't,
yeah.
in case the patient is doesn't fit have insurance, then we send it for a discounted price either
So
to
like
Medgenome or
what I wanted to ask, like for you to
Sir,
therapeutic point of view, say like what least investigation you want
least
that
only pole, at least for pole. And even
for a med.
TP53 can be done on IHC.
So no, I'm talking about this particular case, like this
sir, I would like to add that yes,
MMR.
sir. Sir, actually, I would like to add
Yes, sir. Yeah, ma'am.
that, sir, if a patient is a metastatic case at upfront
Hmm.
and not affording for the entire panel, the bare minimum
Yes.
I offer to my patients is these three things:
Yeah.
ERPR on IHC,
Yes.
HER2 testing,
Hmm.
and MMR testing on
MR
IHC. This
testing.
is
Yes.
something which I offer to my patients.
Yes. Yes. Yes.
Uh,
Yes. Yes.
yeah, which
Yes.
helps me decide the
Yeah.
treatment
Yeah.
plan also.
Decide that. Yes. A lot of things it helps to
If
decide.
he can afford, then definitely the entire panel is the best
Definitely.
thing.
The entire panel is the best. So that is there. That's what I also feel like. If bare minimum we have to give, then at least the MSI status and HER2 and along with the DRPI status. That is bare minimum we should go ahead with. Yes, ma'am. Any insight, yeah, minimum, any insight on it, like in your practice?
For endometrioid variety, I just missed the
Yes.
histopath of this particular case, but if it is endometrioid,
Yeah, it's a
uh,
great treatment, right,
yeah,
ma'am?
endometrioid, so the
Mm.
basic would be the P53
Mhm.
and MMR. Like if for a non-affording patient, we get a minimum of P53 and MMR
Mm.
because that would alter the histopathology in general. And
Mhm.
it is only for serous that we are doing HER2
Yes, HER2. Yes.
because it's common in them.
Yeah.
And poly also because if it is already metastatic, I think it might not
Metastatic.
alter
Yes,
for this
let's work. Yeah.
particular case.
Yeah. Yeah. It's a
Uh,
metastatic case, ma'am, to
yeah,
present with the
so
metastatic. Yeah.
if they are not affording, those are the minimum IHC, two IHCs which we are getting,
Mm.
P53 and MMR. If they can, then obviously the entire panel would be
Panel should be
helpful.
done. Yeah.
Dr. Nishant, hello, this is Dr. Avinash.
Hey,
Hello,
hello,
everyone.
Avinash.
Yeah.
Yeah.
But I would like to add, as Yamini ma'am said, for nodal dissection, there is a decision. So, on the biopsy, we will do the molecular profiling. And also, if we are giving, if you are going for an interval cytoreduction and we are giving some induction type of thing, then I would also like to do, in that case, also a molecular profile on the biopsy specimen. And for
Mm-hmm.
me, I would like to do a DMMR and P53, as ma'am said, and
Yes.
HER2, most of the serious cases, as ma'am said. But I would also like to do a poll because if we can and we are going to add immunotherapy to the chemotherapy, then that might help.
Hmm. And how often NGS, like in your practice, like the whole panel NGS, like how often that you go ahead with the NGS?
Yes, so whole panel is obviously
Recommended.
everyone wants that.
Recommended.
Yes,
But is there any
recommended.
soft indication that a particular kind of histology or something profile that you would definitely push that KNGS should be run for such patients?
No, if you are going for initial therapy, then I don't think we require that. But if the patient is affording, then we can do it.
We can do it. Okay. So for this patient, it was found to be DMR and MLH1 and PMS2 loss. So and then MLH1 methylation study was done. It was found to methylated, pole wild type and P53 wild type, HER2 negative, ER 60%, PR 20%, and patient was also done for the NGS that suggested a PIK3CA PTEN ARID1 mutation. Okay. So what next step would you go ahead as the medical oncologist, the panelist, anyone can can go ahead. Like what next plan will you start with? You go for a systemic therapy with the chemo with Pembro or Dostar or IU alone or any other options that you have in your general practice? Anyone of
I would
like
like to, as this is DMMR patient, I would like to go ahead with chemo plus dostarlimab for this patient if cost or if there is no other constraint.
uh-huh.
Because with dostarlimab, there is also, I feel, OS benefit
Hmm.
and the DMMR benefit for these patients with dostarlimab is massive, sir.
And
And
we
then
have a hardcore data now, printed data we have for this.
Mhm.
Yeah. Any other view on it? Like, are you
Uh,
alone? Like any kick on, are you alone or chemo alone?
Age, sir,
no.
Frail enough
She's
to
60.
tolerate
She's
chemo,
60.
then
She's
IO
60.
alone. Then like,
with
yes,
patient, if age is also
Fit
not this thing, then
Yeah,
we
yeah.
can go
Yeah.
ahead with chemo
yes,
plus I.
So
chemo
I
plus
also
dostarlimab.
I also agree with Namrata ma'am. Platinum doublet chemo with dostarlimab is the best option here. Because the patient is fit, PS is 1 and she is 62, so I think she's going to tolerate it.
Hmm. 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 Okay. So any idea, any view on this Lenva with Pembro, like upfront to use with for such patients or something like in your day-to-day practice, like if the patient like instead of giving the chemo, like Lenva with Pembro upfront, any experience with that or any such practices in general that we are finding?
Sir, in endometrial, I have not yet used Lenva with Pembro, but based on the experience from RCC, sir, Lenva
Hmm.
Pembro combination is something which is not that easy to be tolerated as
Hmm.
compared to
Hmm.
platinum doublet chemo with
Pembro,
IO.
single agent IO, yeah.
So Lenva Pembro will not be my first choice, sir. Here.
Any other anyone else who wants to just to put an sight on it?
Sir, I have given Lenva Pembro only to patients who have progressed on platinum chemotherapy.
Doublet.
So yeah, on first line I have not used it. So
Yes,
yeah.
yes. And I think we have that clear trial, if I'm not wrong, that has actually no, not clear. I'm just forgetting the name, but it clearly says that like Lenva Pembro has not reached actual
Leap trial success.
a leap trial, yes, which has
Yeah.
actually said that the trial did not actually
Yes.
reach to the endpoints, pre-specified endpoints, where chemo was compared with Lenva with Pembro. So it actually so in first line settings, it's actually not acceptable to use Lenva Pembro in a fit metastatic patient. It's better to start with the doublet along with an IO, whether it's dostarlimab or the Pembro. So any specific experiences with difference between Pembro versus dostar in your day-to-day practices, like any specific difference that you find in the toxicity profile or the patient, except for the cost constraints? Any other major difference that do you find, like in your experience?
Dostarlimab, even there's a 4 weekly dose, if I'm not wrong, which can be
Yes,
given. But with
yes.
Pembro, that is not possible, sir. So if a patient wants to come after a long period of time, not visit frequently, then we can proceed with Dostarlimab. That is the only difference. I think now both cost of Pembro as well as Dostarli is 10 to 11 lakhs for the whole treatment.
Ha. Okay. So we can come to a common consensus that yes, we'll go for the platinum doublet along with IO, whether it's Dostar or Pembro. Okay, so now the patient was started with the same. Acha. Now tell me, like here, do we have any molecular classification importance? Like here, like we discussed actually this point, like HER2. So for this endometrioid carcinoma, we will, if possible, we should go for the whole panel done. But HER2 mostly, as the Yamini ma'am has pointed out, that's more towards the variant and more important with the clear cells. And how often that we go for a PDL1 testing, specific PDL1 testing? Do you practice there in your day-to-day practice for day-to-day clinics for endometrial carcinoma? PDL1 testing is separately other than the patient. If the patient has been MMR proficient, do you go ahead still with the PDL1 testing?
No, sir. At present, with the paucity of data, no, sir.
Yes, we don't have any actually any evidence of doing it for this. Yeah. So an NGS we have already discussed. So the patient was, and these are the important the trials that we have. So any experience with Duo E, adding olaparib to your therapy? Like is there any good evidence or good experience with you people in your clinics, like adding olaparib to the platinum doublet with IO? That's what the Duo E third arm was there with adding olaparib. Any experience with that?
No, sir, I don't have.
Okay.
No, sir, not yet.
Same, sir. No experience.
Okay. So now the patient was started on the plan was there, like platinum doublet along with IU, and patient has shown a good response. to the therapy. So what is maintenance plan that you people generally follow? Like in your clinics, what maintenance? Like after 6 cycles. So how many cycles of doublet and IO you generally prefer before starting the maintenance?
Usually, sir, 6 to 8 cycles is
Hmm.
what which we follow,
Yeah. And then
followed
maintenance.
by
Yeah. Yeah. So
Um,
maintenance, yeah, tell me.
Yes, my preference will be after 6 cycles only. And maintenance here also, if it is DMMR, then as the patient is, then maintenance with IO will be, I think, very
Wise. Yeah.
beneficial than PMMR.
Yeah.
Yeah.
True. True. But still the data doesn't actually, yeah, you are perfectly right on the biology of the disease, but still the
Yeah.
data says that after 6 cycles, whether it's P or D, MMR, the maintenance is but we can continue with IU maintenance if the patient shows a good response. But yes, it is a good point that if it's a PMMR,
Yeah.
then we have to be little skeptical about it,
Yes,
whether
yes.
continuing a single agent in that way if the patient progresses. Okay. So maintenance, so like the DUO trials, so third arm was suggesting that the Pembro with along with that using the PARP inhibitor, like olaparib to them. So as we discussed, like there is no as such any experience with that. So the point that I wanted to highlight here is that like many of like where NGS actually helps us. So those patients with exactly the concept of BRCA doesn't comes here. That how it holds in other places. So like in ovary, but here also it has been seen, or there was some, what I recall that in some supplementary paper of the DOE, they show that those patients with BRCA genes mutations found in the NGS showed a little benefit of adding the olaparib to the Pembro maintenance, like the Pembro with olaparib kind of thing. Okay, yes, it is a toxic regimen overall to continue post chemo with Pembro and olaparib. Long term complications are quite huge with such, but yes, it was there. So if at all we are supposed to justify that the NGS panel to be done such patient, then we can actually do with the benefit of adding olaparib to the maintenance cycle. But yes, it is, the data is not that strong. But just for the for the discussion point of view, I just wanted to get this out. Okay. So now the patient has been,
query about the PDL1, like just for my knowledge,
yes, ma'am.
that
Yes, ma'am.
suppose if it is a deficient MMR, like in this case, then
Mhm.
probably PDL1 will not help in any way. But
Mhm.
suppose a proficient MMR patient is there with metastatic disease, there are indications for Pembro addition and or Starlima for these metastatic cases. So in those cases, suppose like especially if there's a cost issue, doing a PDL1, does it help in guiding how much benefit the immunotherapy will provide to the patient?
So
Like,
yeah, very nice
like
question. Anyone want to
it,
take it up? Uh,
can
like
it,
in like in a tumor
if it
agnostic
is,
form. Yeah.
as in like, yeah, prognosis, the how much benefit the IO will give to the patient, can it guide in that?
Anyone
Doing
want
a
to take it up?
PDL1 testing or the PDL1 levels? Or there's no role at all, like in endometrial CA, we should like.
Dr. Namrata or can anyone just want to discuss on it?
Ma'am, no point in doing the PDL1 because even in stage 3, irrespective of the PDL1 or DMMR status, we are adding dostarli now.
Hmm.
So,
So like it there's no like guidelines basically to support
no
that.
guidelines, ma'am, at least for endometrial cancer.
Okay.
Yeah, for
Irrespective of the PDL1 status, we can
Yeah.
add both Pembro and Dostar.
Yeah,
So,
that
the benefit for the patient is not here. So, it will be
No,
only
I
like,
guess Yamini ma'am wants to just know
like
that
ma'am
if
is
suppose
like
the
I'm
CPS comes out to be 0 or
yes.
CPS comes out to be 20, then
Hmm.
whether that value will help in explaining to the patient that, okay, you will derive more benefit. I guess if I am getting it right, ma'am
yes,
wants to know
correct.
this
Yeah,
thing.
yeah, that
Yeah,
was the
that's what ma'am is
like
asking. Yeah.
question.
Hmm. Like in other tumors, we actually predict
Yes,
the
exactly.
Like if
responsiveness.
the patient, if it's a big thing for the patient to invest the 10 lakhs, can it guide in
Yes.
like them making the decision
Like in
whether
like
the
what we
benefit?
talk about in the tumor agnostics. Like in tumor agnostics, if we get it done and
Yes,
we can
yes,
just
yes.
further add to the justification of what we are giving actually to the patient. Like in other tumors we see.
Yeah, like in lung we do, and in breast also
Hmm.
we do. But hypothetically, it
Yes.
should be in endometrial. But ma'am, at present there is no such
Yeah,
evidence,
there is no
and we cannot
guidelines to support it,
have
and I think
evidence.
nobody is practicing it. So
Hmm.
Yes, ma'am.
okay. Okay, thank you.
So once actually, ma'am, it's very interesting. Once I think we had discussion in our OPD only, ma'am. So once I just went through it, what I found that is those patients who have been like those patients, when we specifically talk about the DMR status. So if the DMR is there, then it is predictive. The responsiveness to the IO is well justified. But if it's negative, if negative, in that case, it becomes a question dilemma that key whether we should before offering the agent, whether we should go and another marker to it to just justify that ki such a expensive drugs we are adding to it. But currently we don't have any evidence in when it comes to the endometrium and that whether we should get a PDL1 testing specifically done to see for any CPS or TPS score for that. So
Yes, so
currently,
no
so yeah,
evidence, but maybe or like
maybe a
if
exploratory
we
kind of,
yeah,
ma'am.
we would need to get the data if we want to
Yeah.
start it, like, but no data to support.
No, currently through.
Thank you.
And yeah, and what about if patient comes out with HER2 positive? Then what approach that you people follow? If the patient is HER2 positive as a DMMR, then in that way, what is does how the treatment plan changes? So it's like dual positive. It comes out to be like we get a target of HER2 as well as the patient is DMMR. So
But
the
still go
treatment
ahead
change.
with DMMR, I feel, sir.
Yeah, true.
Uh,
Yes, yes. We'll go ahead. There is no fun of adding
Right.
the HER2 directed therapy. Yes, perfectly right. Yeah. So now the going back to the case, the patient is now classically progression happens. Initially, there is a progression of single liver lesion progression. So what is your take on it? Like if it's a isolated liver, like do you want to go localized therapy? And what about the continuing the IO? What is the take? The patient is on maintenance or any reintroduction of chemotherapy as well to it, just like what we do in case of colon.
If the patient
Yes,
is
sir.
on
So if
pembro,
no, ma'am,
please
please
proceed.
continue.
Please proceed. No, no, please
No,
proceed.
ma'am, please.
What I felt is if the patient is on maybe single agent maintenance pembrolizumab, then maybe we can add lenvatinib if the lesion is very small. Otherwise, if the lesion is still very small and there is no disease elsewhere, go ahead with SBRT.
A curative intent, still in a curative intent,
Hmm.
kind of. So either adding lenvatinib to it or reintroduction of a chemotherapy. For example, there is no exact concept of platinum sensitivity when it comes to endometrium. So if the patient is on the platinum doublet, say after 1 year and patient is on good maintenance, doing okay, the patient develops an oligo progression or oligomets kind of thing. So whether reintroduction of chemotherapy to the existing IU or lenvatinib introduction here, what is the take about it?
If
I hope you understand. Yeah.
Sir, I actually
you can
Yeah. Tell
proceed, Sabine.
okay, ma'am. Thank you, ma'am. So, sir, what I usually do is if it is already 12 months after my patient has been on chemotherapy
Hmm.
and there is a oligoprogression, if that is locally addressable, I would want to address it locally. But
Hmm.
most of the time, sir, I do not emphasize on the local therapy. I just reintroduce the paclitaxel and carboplatin, which
Yes.
I had given the very
Yes.
first set.
Yes.
And then I
Yes.
continue IO and with a very
Yes.
close follow-up, obviously.
Yes. 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 Yes.
So
Yes.
unlike lung cancer, in
Ah.
endometrial cancer, unless that oligoprogressive site is very much symptomatic for my patient,
Hmm.
I do not emphasize on getting it locally treated, sir.
Hmm. Rather, again, hit it hard with the chemo backbone.
Yes, sir.
Yes. 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 Just like what we do in lungs, like once a patient progresses on PEM carbo, we first introduce carbo before adding anything else. Yeah.
So,
Okay.
Yes,
Any
sir.
other
Dr.
take on
Nishan,
it?
can we do this if there is a oligo progression? We
Mhm.
give the local therapy and continue the IO and see how the patient does.
So yeah, like what has been said by said by her also, like it's if it's less symptomatic or something, then either
Yeah.
go if it's local therapy is feasible and viable, yes, we can again curing the particular local site along with
Yeah.
continuing the IO. So, and if it's symptomatic or bulky kind of thing, then better to introduce a cytotoxics to the backbone of the cytotoxic backbone. Yeah,
Yeah. And
makes sense.
whether this is a deficient MMR and proficient MMR, that can help.
To further, yeah, so the thing is
Yeah.
that as you only pointed out, like if it's a deficient mmr, then IO backbone I would like to push as much as possible,
Yeah.
as long
Yeah.
as possible. Yeah.
Yeah.
So as long as possible I would like to push it up, and if it's a gross progression, bad progression, then definitely the therapy has to be switched the therapy has to be switched. In that case, continuing IO will not be bringing much of the change. And again, it's like 12 months or 6 months because we don't have a clear-cut sensitivity, platinum sensitive concept when it comes to endometrium. So yeah, so that is again a question, that how early the patient is progressing, how badly the patient is progressing, what are the sites of progress, soft tissue progression or a bony progression, that will actually decide, and obviously the PS of the patient. So any experience of IO with chemo followed by IO with Lenva? Like once, you pointed out that adding Lenva to it. So what is that? What is take of that particular thing? Like IO with chemo performing well, then patient progressing on IO maintenance, introducing Lenva to it.
We recently did the same for a patient, sir. And for the post 3 months reassessment bit, there was response. So we are currently continuing. We don't know how long the response
Yes,
will
yes. So it can be an option for a fit patient with less bulky disease. We can actually think of adding lenvatinib to it. And what dose of Lenva are you using for that patient?
That patient is not able to tolerate more than 8, sir. And she's not that compliant too. Sometimes she takes 4, sometimes 8.
This is what a problem. I think mine and Yamini ma'am's patient is also there, one of the patient. Like it's difficult to actually continue with a good dose of Lenva. Yeah, it is an issue.
I think there are only very few patients who can tolerate more than 8 mg Lenva.
Yeah, even it's a
Agreed,
talk about
agreed.
RCC. Yeah, RCC also, it's very difficult to go
Yes,
above
yes,
it.
exactly.
It's very difficult to go above 8. And I think Indian setups are
Yes,
doing well also on 8. What I find that they're doing well on 8. It's not like that all of them requires a good 12 or 18 mg. What I feel like.
yes, most of
True.
them do. I
Hmm.
agree. Yes.
Yeah.
Our chemotherapy doses as well as our molecular TK doses vary when compared to the Western world.
Western data. Actually, this is a good topic that we can actually look into the data, like the low dose versus the standard dose kind of thing. Okay. So the patient, what I suppose that we can continue with the IU, and if feasible, the local therapy can be done for the patient if it's feasible, and continuing the IU, or plus minus adding the lenvatinib if it's there. So now the patient again comes to the diffuse progression after so the patient was an IU with chemo, with IU maintenance, now has initially had an oligo progression, and the now patient now have a gross progression. Currently, the patient was still on the continuation of the IU. Okay. So what next? What next will be the approach? How we proceed in the clinics?
This is post local treatment followed by IU.
Yeah. Now the patient is progressing badly.
If her PS is good, then go ahead with chemotherapy.
Yeah. So what chemo, like Abhi, at this particular point, like what do you want to reintroduce? You want to reintroduce the platinums? Like earlier, the platinums were not reintroduced. If you want to reintroduce the platinum here,
Yes, earlier if they were not used, then we can reintroduce them now. In case we have already reintroduced before and still the disease has progressed, then maybe
progress.
go ahead with lipodox or maybe gemcitabine based combinations.
Any other view, like
Yes, and
any
also we can add, I guess, there are good phase 2 evidences of adding bevacizumab also to
yes,
chemotherapy second line setting
yes,
onwards.
yes, yes,
So if the
yes.
patient is fit enough to tolerate that and no many contraindications, then we can add that.
Bev with a chemo. Yeah.
Yes, yes, sir.
Okay. Yeah. And what generally what you prefer if you are introducing the Bev, then what chemo you prefer in general?
So with Bev, actually, I have used paclitaxel and carboplatin only. I have not used it with lipodox at present. Lipodox I have used as a single agent therapy only.
So,
Even
but in
lipodox. Yeah.
but in cases of ovarian cancer, we have used lipodox with Bev and Gem with Bev. So that is that can also be an option here.
Yes, so when in my residency days, we were actually using one of those backbone of either lipodox or gem and bev was being added. Yeah, and it was actually quite tolerable, and no, it was all okay. And but yes, one thing was that here the ovary wala concept of using 400 versus that is one order, like full 10 mg, at least 15 mg per kg was actually recommended dose here.
Yes.
It doesn't hold good that holds there in ovary. Yeah.
Yeah.
So it is there. So what about endocrine therapy? Like she was 60%, 40% ERPR.
Endocrine therapy, sir, most of the times I have used it in only two scenarios. One, if the patient is frail enough and not able to tolerate chemotherapy, and the progression is definitely diffuse, but not
Bulky one.
heavily progressed. Okay. Yes, bulky. And secondly, sir, after I have given second line chemotherapy, suppose I have given 6 cycles of lipodox. Now I want to put my patient on something, then I will introduce endocrine therapy as a
Yes.
maintenance form of
That's
therapy.
actually, yeah,
So
yeah.
these are
Actually,
two
is a
scenarios that
good
I've
thing
used it.
because we have to seal the lipodox or any other cytotoxics.
Yes, sir.
Yes. Yeah,
Yeah,
it's a
since
good
there
thing.
is a diffuse progression, we would first like to go with chemotherapy, then we can put on maintenance
That's
endocrine
what.
therapy.
If a patient is
Yeah, yeah,
tolerating with a
yeah,
good tolerating patient, then better to go for the chemo. And if at
yes,
all
yes.
the patient is in bad PS, then yes, it's a kind of hardcore palliative setting. We can just go ahead with the only endocrine therapy that is there. So, and what about in targets that you people are actually looking into in this particular scenario once the patient has blown away with all the therapies? How much like is there any good clinical experience with targets?
Uh, Only with sir HER2 and this bevacizumab. Tissue
Yeah.
agnostic, sir, we can use anyways.
Yeah, yeah.
And
So in
also
HER2,
data
HER2,
using CD.
and for HER2, like what is the preferred one? We go for Herceptin or we go TDX, like the advanced versions. What is your take on it?
Sir, for first line, sir, trastuzumab.
Hmm, 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 Yes, mostly the trastuzumab. Yes, and along with what chemotherapy backbone.
Yes, sir. And so there are also data of combining palbociclib and abemaciclib with endocrine therapy.
Yes, just like the what we do here, there in the breast kind of thing. Okay, and any experience of adding anti-PIK3CA like?
No, sir.
As such, there is no. So that's
No.
what like here the NGS actually gives some answer, but all these have not got any good evidence or any strong evidence to actually add the cost of the added toxicities to the such patients. So if the patient is fit enough, we should go ahead with the reintroduction of platinum doublet or something. If the patient is progressing on platinum doublet, definitely we have to switch to another chemotherapy, which includes single agent chemo with a second agent, which could be a target that a targetable mutation that we have either HER2 or if potentially other targets we can have. And as a very good point that came out to be, once the patient has shows a response to the chemo in any of the settings, then we can actually introduce with endocrine therapy to them if the patient is having any positive markers. And in a hardcore palliative settings, so if the endocrine ERPR status is positive, then we can go ahead with the endocrine therapy itself. Yamini ma'am, if you have any further insight to it, any other experience at this particular point of time when patient has progressed to most of the therapies?
I think whatever was said was quite comprehensive, and I agree with all the discussions.
Ma'am, any role of
Yeah.
palliative surgery, like ma'am, like out of the box completely, I'm asking.
Uh, Palliative surgery, yes, in endometrial cancer. Uh, in this particular recurrence, the oligo diffuse, what stage are we talking about?
So ma'am, we're talking both the condition, like oligo, if there is
Yeah.
like liver lesion, and then obviously ma'am, when if it is there, like patient is too symptomatic.
Palliative surgery, like in endometrial cancer, if suppose a patient is stage 4, initially inoperable, there is a definitive role of interval surgery. So that
Okay.
is there in all the guidelines as well. So even in a stage 4, we after giving neoadjuvant therapy, guidelines do recommend going in for a palliative cytoreduction, interval cytoreduction, even
Okay.
though we are not very sure how much survival benefit it would provide. So, but that is one scenario where in metastatic disease, in interval setting, surgery is being done. Other than that, probably somebody who has not had had an hysterectomy in the past, and
Yeah,
in
that is
those
the thing, ma'am.
cases,
If patient, yeah,
So
if
for
a
the
patient
pelvic
presents,
symptoms,
yeah.
yes, for palliation purpose, that might be possible.
Okay, ma'am. Okay. And any HIPEC or something, ma'am, there any role of such thing, ma'am, here?
Not really like aware of HIPEC for endometrial.
For endometrium, yes.
Also, like
So
for the ER, for the hormone therapy, like what is the cutoff? Is it more than 60% to give the hormone therapy, the positivity rate, or how much like is generally considered?
So anyone want to take it up? Like what
Then
ma'am?
or equal
Yes,
10% is still what they
10%
have
is
given in
Okay,
the guidelines.
more
But
than 10%.
uh-huh.
So ma'am,
And
actually this enough is 10% is quite enough for
okay,
this
okay.
two system the plan for therapy. Again, if the patient is presenting with the brain mets, then the same question comes, like it depends mostly on the symptom, how much symptom is that, single lesion, SRS versus surgery, systematic therapy. So I think it holds good with what we have discussed in the isolated liver lesion. Like we can switch the therapy accordingly. So anyone wants to take it up, like any specific thing to be added for brain mets, like isolated brain mets or a progression as a brain met disease? Any specific changes we want to bring in your therapy? Anyone, like is specific for the brain mets, any changes?
If it is a
Sorry, sir,
single
not
agent,
aware of any.
if it is a single agent local therapy, then continuation or change of therapy, that depends on the symptoms. But as such, there is no
No specific
difference
change that
from,
we need
yeah,
to bring.
yeah.
Yeah.
Brain
Okay.
mets, I like if the patient has GCS affected because of the brain mets. I think if it's like a hemorrhagic metastasis with the midline shift, I think that is the scenario when a surgery is recommended, like which
Like
I think,
emergency, like emergency
yeah,
scenario
yeah,
when the patient comes to brain mets
yeah,
kind of thing.
yeah, that is the only
But there
scenario
is no
where
survival.
surgical
There is no
part.
survival. Yeah, there
Yeah,
is no
just for the like
palliation.
midline shift and to prevent a herniation.
Yeah, and the same holds good for the bone only
Any other
progression
meds?
as well.
Yes.
Yeah. The same thing is that. So I think I hope we had a good discussion on the case, which was quite a simple one. But yeah, we can go ahead. So what I just want to say that yeah, it's endometrial carcinoma. As I again want to repeat it, like I find it often very too much changed and advanced nowadays, and I always go to tell Yamini ma'am, let's discuss the classification again and the molecular part again. So it's, I think, most important as the team in oncology, we should treat endometrial carcinoma according to molecular types, definitely the stage. And for a metastatic setting, chemo backbone with IO is a first line therapy. As such, we don't have a strong evidence to support IO with lenvatinib as a backbone or only chemotherapy to start with. It must be an MDT. It must be discussed with the surgeon and the radiation oncologist and the medical oncologist and the gynecologist regarding the proper management of such patient. And whenever possible, a clinical trial should be put on. And I think as we have dived down to the molecular classification and a lot of molecules have come up in endometrial carcinoma, I hope the time is not that far when we have a lot of target drugs also for endometrial carcinoma, both in the palliative as well as in the curative settings. So thank you so much. I would love to hear from all the panelists. Like it was a great discussion, and thank you to the team for having all of us here.
Hello, sir. Sir, I would like to know one thing actually.
Yeah.
Sir, the same we discussed in endometrial cancer, like which block to send for molecular profiling. Does it apply similarly to ovarian cancer? Like, should the upfront block be sent or after like
See
interval
what
debulking surgery, whatever we get
see
for
what
HRD testing, sir?
Yeah, so what I always take what I have been trained and I have discussed that always the untouched tissue is the best tissue for any kind of molecular testing if we want to discuss at all. Okay. But yes, the
Okay.
caveat comes that if a patient has progressed on previous therapy, then it should
Okay.
always be a repeat biopsy from the metastatic site, most evident metastatic site, to see for the changes
Okay.
that we can actually have at the molecular level, just to search for options of the treatment. Okay. So if we specifically talk about CA ovary or CA ovary, so where surgery
Yes, sir.
and neoadjuvant are quite hand in hand, it goes. Like most
Yes.
of the patients actually require induction, neoadjuvant therapy. So in that case, if you
Yes, sir.
talk about HRD testing specifically, what I would recommend, it should must go with the baseline, the index tissue that we have. Okay. Yes, because
Yes.
if we integrate the patient with a neoadjuvant therapy, it supposedly it may bring it's not actually evidence to actually tell that how much changes the chemotherapy will bring to your tissues, but yeah, if technically it does bring about a lot of changes at the molecular level. But yes, if you tell me that the patient has progressed with a curative intent baseline, and currently you have
Yes, sir.
a baseline tissue which was not put for HRD, and now the patient is having a new tissue with a new metastatic site to choose between the HRD testing at the new thing, then that is actually a gray zone. But yes, if you ask me, then it's better to get it done at the baseline. Anyone else has got any view on it?
I totally agree with Dr. Nishant. I think in ovary it is very clear. Like I remember like almost like 7-8 years back, like during my first year of MCH. So that is when like it was relatively new, I would say, germline and somatic. So when the med genome and all these people had come, so we had a good discussion on this. So they were very clear that the preferred specimen for them is the upfront biopsy, because especially if the response is very good in ovary, then the tissue which is there in the interval surgery part might be insufficient. If at all the initial blocks are not there and we want to send the interval surgery, then they had given a cutoff, I think like minimum 10% or something of that much tissue should be there. But it's very clear that it should be the initial tissue.
And many a times, ma'am, in AIMS, we used to find, na, like the whole disease gone. It's complete normal
True,
anatomy once
true.
after new
Yeah,
adjuvant.
Yeah.
exactly. Exactly. So it can be quite altered, like
Mm.
post chemotherapy.
But sir, the only concern was that most of the times in ovary, sir, the diagnosis is made on ascitic fluid cell block. So,
So what?
like,
Yeah,
how
this is
much
something
sensitive
which
is
we
that
often
tissue? Yes, exactly.
this very often we discuss. But actually, when we go through the guidelines, we should actually start the treatment after the tissue biopsy has been done. Yeah.
Okay.
Until your patient is and it's actually in a bad shape, to just justify that a cytotoxic you are going to start. Still, I would prefer that I can start with the treatment, but yes, the biopsy has to
Yeah.
be there.
Yes,
Has
I think the treatment
Okay.
can be
Yeah.
started, but the biopsy should probably
has
be
to be there.
taken
Yes.
but before,
Yeah.
even though the treatment is not
Yes.
delayed for that.
Has to be there. Yeah.
Even IHC, I feel like in
Mm.
most of the cases, it is better to get an IHC
Better to
done.
get an IC done properly, ma'am, at baseline.
Yes, yes, sir.
Mm.
Yeah, sir, I
Okay,
have
sir.
one
Thank you.
question for you and all the panelists.
Yeah,
Sir,
yeah.
sometimes I face, and obviously you must be also be facing stage 1A endometrioid cancers, and they have very low risk disease, but the P53 is abnormal. So
Yeah.
in that cases, what should we do? We should put the patient on observation, or we should go for a adjuvant therapy?
See, as per the guidelines, observation is something that you are supposed to do. But it is
Yeah,
just like that when we talk about AML, like we talk about AML, we have the favorable risk and the poor risk. But favorable risk with all the translocation 821, but if they show any kind of uh, associated mutation with it, which is not a part of poor risk, doesn't behave the same way an isolated translocation 821 behaves. Getting my point?
yeah,
So
yeah, yeah.
that the same concept holds here. So it's a TP53 mutant, it's inherently bad. But if you talk me about the guidelines, yes, they need not to be put into an adjuvant setting, adjuvant therapy. But
Yeah.
yes, you with a pinch of salt that they are going to perform poorer than a non-P53 mutant. So, as per the guidelines, it's difficult to justify an adjuvant, hardcore adjuvant to it. But yes, they will not perform the same way.
So the question, the low grade endometrioid is like limited to the endometrium, or
Yeah, stage 1A disease. I have
Stage
seen
1A,
two
ma'am.
cases, I think.
okay.
Yeah. Stage 1A with P53 abnormality only. And those cases are dilemma here. But
Yes,
I think
correct.
in
I
future we
agree.
can get the,
Yes.
the answers to this question.
Yeah. But at least I think like in future, what I think, even since it is such a lot of it's such an inflamed malignancy, like in future the IU will become part of even the early stages kind of
Yeah,
thing.
yeah.
True.
Just like what we see now in RCC. RCC, there like no adjuvant, everything was failing, but now we have such a strong evidence of pembro there in RCC. Similarly, I think in future, seeing such inflamed disease, IU will become kind of a go-to strategy.
Absolutely.
Mm. So I think it's the co-mutations are also equally very, very important than the histology itself. And I think as me and Yamini already discussed, a good surgery is the backbone of such diseases.
I agree. Like, and in addition to the surgery, I feel all the patients who metastasize and come back, they are grade 3, P53. So P53, grade 3, we should not be missing that. Like, it's very important.
Very important.
Even for the 1A P53 mutant, I feel practically like I would like feel that we should give adjuvant because of how they
It
behave.
should go. Yeah, that's what, ma'am. Yeah. Mm. So, anyone else want to add further? it was very good for me to learn. Yeah,
Thank you, sir. Interacting with colleagues of more or less same age is much more better. We have our own difficulties to share and our own ideas. So this is one of the most enjoyed panel in the recent times.
yeah. And
Very
I
well conducted panel. I really enjoyed, learned a lot from everyone. Like, and
And
we
Yamini
have
ma'am, so I was like in evening only post rounds. I have just ma'am, please join it up, and thank you, ma'am, for joining it in such a short
thank you
notice.
so much. It was my pleasure. Thank you for including me.
Thanks, Avinash.
Thank you,
Thanks,
sir, for conducting this.
Yeah.
Yeah.
thanks, Avinash.
Thank
Thank
you,
you so
ma'am.
much.
Thank you so much.
Thank you. Thank you to all our esteemed panelists for such an engaging and thought-provoking discussion. Now,
Thank you.
as we come to the end of today's webinar, I would like to express my sincere gratitude to all our esteemed faculty members for sharing their valuable knowledge and a clinical experience. A heartfelt thank you to all the delegates for your active participation and for making this session a success. On behalf of the International Association for Integrated Oncology, IAIO, thank you once again for joining us. We look forward to welcome you to our upcoming academic programs. Have a wonderful evening. Stay safe, stay healthy, and thank you, everyone. Good night.
Good night.
Thank you so much.